welcome to my channel. This is Dr. Bess with All Things Nursing. If you are new to my channel and have not subscribed, please hit the button down below, subscribe and follow me. Today I'm going to address the differences between working in an inpatient setting as a psychiatric mental health nurse practitioner versus working in an outpatient setting as a psychiatric mental health nurse practitioner. And this video is for anyone that is in nurse NP school, or is currently practicing, or is trying to change or kind of get an idea how things are done in one setting or the other. And the first difference between the work I do in an inpatient setting versus the one I do in an outpatient setting as a psych NP is in the types of patients that we see and treat. I'm speaking based off of my own experience. In the inpatient setting, most of the times you do not know these patients. They are unstable. Patients come from the emergency room, from home, or they are court ordered, right? So these patients may be suffering from major depression that is severe to where they become paranoid, suicidal, or homicidal with a plan to act on these thoughts. So when the patients are coming from the emergency room, the first thing that I did when I did work in an inpatient setting, if my staff gets a call that there's a patient in the ER who the ER providers want admitted in an inpatient psychiatric setting, the first thing that is sent over are the records of the patient. This is based on the time of the assessment in the emergency room, what they've seen, what they've been diagnosed, and any labs that are done or diagnostic workup. You want to request and review these, because why is this important? This is important because you do not want to accept a patient into your setting when your setting is not equipped or able to provide them with the services that they will need, right? Another thing is because sometimes just because somebody presents to the emergency room and then the ER wants them to be admitted does not mean that they meet criteria to come into your inpatient setting. Why is this important? Let's just consider the case of elderly patients, right? You know, when elderly patients have a urinary tract infection or UTI, they most sometimes present as confused, paranoid, and delusional, right? And it would not make sense to admit an elderly patient in the inpatient psychiatric setting. This is somebody that does not have any psych history, because the ER said that the patient is paranoid, is delusional. No, you make sure you look at the urinalysis to be certain that there is no UTI. You know, when a UTI is ruled out and then this thing is just all of a sudden happening and there are no medications that you think can be causing this thought, then you may want to consider accepting that patient to further see what can be done to assist them. But if the patient has a urinary tract infection, no, you do not accept. Those patients I turn down and I tell the emergency room to treat them, because putting them in the inpatient setting is not going to solve the problem. The patient needs medication to be stabilized, and if the UTI is treated and the patient is not stable, then that is another point of contention, right? You know, and then you could also have a patient that has pneumonia, right? Confusion and all that, but then when they present to the ED, they want to send them to you. You look at the history, and then if they have done diagnostic tests, review those, and then you make the determination as to whether or not you can accept the patient. In accepting the patient, you have to ensure that when you bring the patient to your facility, your staff and the services you provide there will be able to help them get out of there and go back to normal life, right? In the outpatient setting, it's a little bit different. Patient comes to you based on referral from primary care providers, self-referral, they look you online, and they come with things that when you assess them, if you do assign a psychiatric diagnosis, depending on the treatment option that you both decide to pursue, it could be medication, it could be psychotherapy, then you follow them on a monthly or every 2 months basis, right, to review medications and adjust them. So the outpatients you see in the outpatient setting are most of the time stable patients, right, that you've known or come to know, and you guys have a rapport and you're working on addressing symptoms they are still reporting and adjusting medications as needed to attend to this. In the outpatient setting, sometimes you can be forced to refer a patient to be treated in the inpatient setting If they come in, they are paranoid, they are delusional. Just let's assume it's a schizophrenic patient or a patient with major depression that is worsening, and then they become suicidal with a plan. Yes, you can talk to the patient and advise that, and a course in the inpatient setting is very, very important. But then if you deem that this patient is a danger to themselves or others, but then they are refusing to go into the inpatient setting voluntarily, then you have a right as a clinician to send them involuntarily by signing the necessary paperwork. It differs from state to state. In Georgia, it is called Form 1013. You would sign that, and then the staff at your clinic will call the police, and then the police will pick up the patient, take them to the emergency room. They will hold them there while they start looking for a facility that would ultimately accept this patient for treatment, right? So those are very, very big. Number two, the second difference between, no, let's still stay on number one. Another thing in the difference in the outpatient and inpatient setting in regards to admission is the fact that some patients can be court ordered for inpatient admission. So those patients, you will take on them and then you will treat them until they are discharged. When patients come in to the inpatient involuntary, depends on the state. Sometimes you have 24 to 48 hours to be able to reassess their admission status and change that to voluntary if you deem it necessary. But then it gets complicated when they are court ordered on that status, and sometimes they stay like that until they are discharged, right? Another point of difference is the treatment. Yes, in the inpatient setting, you have a few days. It depends on the facility, sometimes 3 days to 14, 5 to 14, 7 to 14 days to get this patient stable and discharged, right? So treatment in the inpatient setting is very, very aggressive, right? In the outpatient setting, when we begin medications for certain conditions, we start very low and gradually titrate. In the inpatient setting, treatment is aggressive, right? Because you want this patient to be able to get back on their feet and go home to their normal lives and not have to stay in your facility forever, right? So treatment is aggressive compared to the outpatient setting, and that's a very, very big point, a very big difference. Also, psychotherapy used in the inpatient setting is mostly group psychotherapy, but in the outpatient setting, psychotherapy is mostly individualized psychotherapy, where a patient meets with his or her counselor on an agreed upon time frame, dates, and all that. But in the inpatient setting, it's mostly group psychotherapy. So you want to make sure that the patients that you group into sessions are able to gain information and participate, right? For example, you don't want to put a patient that is paranoid, delusional, aggressive in a group, because the patient is going to ultimately cause disturbance and the group cannot continue. So you want to pick and choose who participates in the group based on the current conditions of the patient, right? Another thing again that is a very, very big thing for me is that when I worked in the inpatient setting, mind you, I'm both a family nurse practitioner and a psychiatric mental health nurse practitioner, so I felt comfortable managing medical conditions, right? In the inpatient setting, in a psychiatric setting, for example, I worked in a crisis stabilization center where we treated patients with depression, schizophrenia, substance abuse, and all that, right? You are the one in charge of the medical conditions when they are in your facility. That is why it is very, very important to review records and make sure that the patients you do accept, you can attend to their medical and psychiatric needs. For example, if a patient I accept has hypertension or diabetes, I feel comfortable adjusting their hypertensive medications and also their insulin or oral medications that they take for diabetes, right? I feel comfortable doing that in the inpatient setting. But if you do not feel comfortable adjusting those medications in the inpatient setting and there's no one else that can do that, then it will be wise to not accept those patients, right? Because you don't want a patient to come into your setting stable, but then their blood pressure and their blood sugar get out of whack, their blood pressure is out of control, but then you cannot adjust their medications. So it's very, very important to review patients' record. Make sure the ones that you accept are the ones you can really attend to, right? Another difference again is in the discharge. In the inpatient setting, discharge is initiated by staff. It can be initiated by the patient. That is voluntary, right? If a patient is voluntary and you do not think that they should be discharged because you don't think they are stable enough for outpatient services, you are to tell the patient and educate them, right? But if they disagree, you have what we call AMA, against medical advice. Patients are sometimes they are required to sign that form if they want to be discharged against medical advice. When they do that, they don't have any follow-up care arranged by the staff. They are on their own, and then the facility and staff are free from anything that happens to them if they choose to leave against medical advice, right? In the outpatient setting, a patient can initiate discharge if they are transferring to a new doctor that's closer to them, or if they are moving out of state, for example, or if you both can discuss a discharge plan. When you treat patients, you do treatment teams and all that, right? You give an anticipated discharge date. If a patient is stable, that you think they are really stable, you can discharge them, right? They also can request that they don't want to come anymore. If they are stable enough, you can agree to that, but then tell them that, hey, if they think down the line that they would like to start being seen again, then they can come and start being seen. All they got to do is pick up a phone and call, right? Another difference between outpatient and inpatient practice is security. This is very, very important. For example, if you have a patient in the inpatient setting who is aggressive, is disturbing the unit, is physically and verbally aggressive with staff and other residents, you have to do something, right? The best thing and the first thing we always advise is communication, talking. Redirect inappropriate behavior, right? De-escalate the situation. Sometimes separating them from other residents. But then if that doesn't work, you have physical restraints, you have chemical restraints, you also have seclusions. It just depends on your facility where you work at, what the process is. So you just have to make sure you follow those rules and policies that are going to ensure your safety and the safety of the patient and other staff members, right? In the outpatient setting, when you have an aggressive patient, that patient is causing issues, is loud and all that, right? What do we normally do? Calling 911. Most facilities have like a panic button that you push to alert other staff of what is going on, but then 911 is called, or if you have security on site, the security is called to kind of de-escalate the situation and prevent anybody from getting injured, right? Okay, another option is treatment. Treatment, what do I mean by this? If you have somebody in your inpatient setting who you believe that you guys have done all you can do, but the patient is still needing further services, then you are to consult and refer out. For example, a patient with major depression that has become catatonic, or major depressive with catatonic features, or schizophrenia with catatonia, right? Patients like this benefit from ECT, electroconvulsive therapy. If your inpatient psychiatric setting does not provide ECT, then you can refer such patients to facilities that do provide ECT for the treatment of major depression, and then you're going to send their records and then arrange for transfer to that facility if they've been accepted, and make sure that the patient is transferred there safely, right? And in the outpatient setting, if you're seeing somebody for major depression and then you think they're going to benefit from TMS therapy or ECT, but then you don't have that in your setting, hey, you can refer them out, consult with other clinicians in the area that do provide those services, and refer them out. Okay, so this is very, very important. Again, when in the inpatient setting, most times you don't know the patients you are going to see, right? So inpatient stays, patients are unstable. Most patients we see in the outpatient setting are stable and are following up for medication management and things like that, right? Another big thing for me, this is my own opinion, in the inpatient setting where I worked, I carried a stethoscope, a pen light every time I make inpatient rounds. Why? Because in the inpatient setting that I worked, I was the only one seeing, and there was nobody else. There was not a medical provider that was coming to do these things. So I did head-to-toe assessments for my initial evaluations and follow-up visits in the inpatient roundings that I consulted, right? I would listen to patients' heart sounds, bowel sounds, lung sounds, check their eyes, do tests to make sure that I'm giving them the full services of care that they need. In the outpatient setting, I do not have to carry a stethoscope. I don't. I just talk. I mostly talk to these patients, build rapport, get to know them, manage symptoms, and continue to follow them, right? In the inpatient setting, I always wear a lab coat. Yes, I do. But in the outpatient setting, I do not. I dress casually. I go to work in clothes. Sometimes I wear scrub. It just depends on what my mood is like for the day. So, yes, patient assessment is very important. So we make sure that we do all we can do to ensure that our patients get the care and services that they need. All right. I mentioned that inpatient stabilization is a short window, right? But then when we determine that the patient has stayed their course in a facility and they can no longer get any more, we are to refer, right? You have facilities that are more long-term than others. Some places patients can stay upwards of 30, 60, 90 days up to a year. So if you think that a patient you have in your setting will benefit from a longer stay, then you are to work with staff members, social workers, case managers to find a facility that would accept this patient and then arrange for transport to that facility, either via family transport or the facility that they are in takes the patients to the next facility, or share it. Depends on the patient case, right? What else can I talk about? Again, assessment treatment in the inpatient setting is robust. I mean robust. Treatment in the inpatient setting is robust. You have a short window to treat this patient, so you want to be very robust in the treatment options you pursue to ensure they are stable. But in the outpatient setting, treatment is not robust because patients are mostly stable, but you are managing the symptoms that comes up and adjust medications gradually. You go low and slow, right? You titrate medications based on response. In the inpatient setting, it tends to be more quick because you have a quick turnaround to get them out and about in society. If you have not subscribed to my channel, please do so. Leave me any questions you may have. Follow me. I hope you enjoyed this video and stay tuned for the next ones. Thanks again for watching. This is Dr. Bess with All Things Nursing.